tonight. Oh, let's start with the most important thing. This is the quarterly staff meeting at Home Rehab LLC. This is the first meeting of 2016, and it's being held on March 2nd at the Northampton Library. The first thing on the agenda tonight is the new admission workbook. This one is all mock-up. It's the only one that I have. I wanted to point out some of the features that have changed and that you'll be seeing in the new books. Obviously, you can see there's no calendar on the front anymore or on the back. The appointment calendar is now a section in the book that has a tab that your patients can find, and there's 3 years worth of a calendar in there. So there'll be no missing at the end of the year. You'll always have a calendar that works for you. We've also done the same thing with the tracking calendar, so that patients can use this even after we've discharged them to record those measures. Also, there is in the very back, there's a section now for the home exercise program form. Obviously, these are all our home exercise programs are up in Devero, and everybody can print those and give them to their patient, but if you feel this is a more appropriate method, you could write those exercises in here. As always, there's the huge section on prevention of rehospitalization that we're all using to train our patients so that they stay out of the hospital. I'm all initially when we do that. And the emergency preparedness section, which as I reviewed it, I realized does not have a lot of information about snow emergencies, and I do now have a special handout that I'll be adding into all these books in the back pocket. Just because that's the most reasonable emergency I feel that we would have in our area, and I think that information needs to be in there. And that's it. Everything else is mostly the same. And the front cover is now big enough to cover over the tabs so that if your patients are using the book like this, they should still be able to find the cover and get back to the front. That was one of the issues that we had before. And that's it. What to say about the book. If you have any questions, they want to ask about the book. Excellent. At this time, I'm going to turn things over to Barbara Piskor. Barbara is not only an RN, but she's the president of BKP Healthcare Resources. Barbara is acting as a consultant to our agency to help us with quality improvement. Barbara was formerly with the Joint Commission, the Area Agency on Aging, and the VNA, and she has over 40 years experience. So please listen to what she has to say. Thank you.
Hi, everyone. Hi. We'll have a pretty informal session with lots of material that we'll want to cover, but we can take some questions, during the time period, and we'll try to watch the time and have you out of here in an hour. But it's always great to meet with staff in this kind of a session. I really am impressed that there are the quarterly meetings and as well as the weekly messages that you all get. There's good information in them. I think that works out well. Help me to know who all's in the room. We won't necessarily go around with name by name, but how many nurses? Okay. PTs? Okay. OTs? All right. Speech? All right. So, a good sprinkling of everyone then. And we're all on a roller coaster right now with healthcare, because whether you're doing home health full time or in a SNF or in an acute care facility, a long-term care hospital, we're feeling a lot of feedback, and it's mostly from CMS, Medicare. Lots of changes, and if you're like most people, we're complaining like crazy, but there are some good things, honestly, with it. How many, give me a feel for how long in home health? Any newbies? 1 year? Okay, so first time around. Okay, how many 5 years and more? Okay. How many 10 years and more? Okay. 15 years and more? All right. There. Well, for therapists, who have been 5 years or more, one of the big differences that especially the PTs are probably seeing when we take a look at that documentation piece, anybody in that whole era of when you said, well, the patient can walk 25 feet, and then the next visit it was the patient can walk 30 feet, the patient can walk 40 feet. That was ordinarily the kind of sequence that we'd see. Well, it's a whole new era now related to documentation. We're really very much more person-focused and function-focused. And we'll intertwine all of that. But I'm always interested in how people get into home health. Who all's working still yet in an institution in a bricks and mortar spot? Okay. And what made you interested in getting into home health? Just sometimes it is extra income. That's a reality. But what was it about home health that attracted you?
Flexibility.
Flexibility, okay. That's good. Okay. That's the reason I ask that is I think the professions as well as healthcare in general have some preconceptions about home health, and that struck me many years ago because I've been working a long time, and the bulk of it has been in home health, hospice, private duty. In a variety of roles, from clinical bedside care to running agencies and surveying. And one time I had a little stint with teaching community health nursing, and one of my students for her senior project interviewed people about their perceptions related to home health and nurses who went into in-home services. And I suspect this would be true with therapies too. But she interviewed a variety of people. I think it was just a kind of a convenient sample of people that she met and then summarized it. And she found the extremes. People who said, those are nurses who want to be independent. They can work on their own. They're almost like doctors. They thought that was a compliment, okay? We know that's not always the way it is. To the other extreme that said, nurses work in somebody's home. I guess they can't get jobs in hospitals. All right? And that's what we're dealing with, I think, in home care, and how that perception then leads into regulations and the various rules that we have to follow. And then that is there as it relates to referrals, as it relates to acuity levels with patients, the types of referrals and all. That's been happening for many, many years until now. Now we have the best of times. We have a spotlight on us with a lot of recognition that we can make a difference. And that spotlight, though, brings the good, the bad, and the ugly with it, because now we're being recognized for the difference that we can make in regard to clinical outcomes. And what's the guiding rule that is it seems to be influencing almost everything now? It's avoid hospitalizations, right? That's the primary item. We're getting scored on it. We're getting dinged because when there's a readmission, when we had nothing to do about it, somebody else called that shot. But avoiding what is thought to be an unnecessary complication. And we're getting measured now on clinical outcomes. Again, for those of you in the field for a long time, always we were scored on volume, how many visits were made, but now we're looking at those clinical outcomes. And really, I think to all of us as health professions, isn't that a good thing? Because we can make that difference. But that spotlight isn't always pretty, especially when we take a look at it in terms of documentation and how we are reflected then in that documentation. And so we're going to try to keep that in mind with some of the content this morning, but also just want to talk a little bit more of some of the trends that's pushing the industry also. The whole payment system has changed. Under traditional Medicare, it's episode rate, so the number of visits really don't matter. The clinical outcomes do, but the numbers of visits don't matter, except on the expense side, not on the revenue side. And that rate, if you're any of you who are working in SNFs, how many work in long-term care? You're used to rug rates and how that rules almost how you use your time, how the documentation is, and what the facility then gets paid, for that. With Medicare, traditional Medicare on the home health side, it's the same system, but we use OASIS for that collecting item. In the SNF, it's an MDS, but called OASIS on the home health side. But it based on the assessment that's reflected in that OASIS is then what the payments made. So it's very comparable with the rug rate, essentially, there. However, under managed care, managed care, Medicare Advantage, it is still on a per visit basis. The big difference that's coming down the road is value-based payment. And that again is tied to clinical outcomes and your documentation, so that the measures, if the patient gets better and there's a good clinical outcome, you'll see higher reimbursement rates. If that doesn't occur, then and it's not only that better clinical outcome, but it's also the client satisfaction surveys that play into that too, with that value-based care. We also have something that's coming that's bundling. Is anybody familiar with the comprehensive joint replacement payment system now? Okay, that's really going to affect all of us, quite a bit. Philadelphia is not a test market with it now, and one of your handouts, you don't have it colored, but I think it's the very last item, describes that joint replacement. This shows what Medicare is thinking about for the future. They're playing around with this now. It's going to get started, unless it's delayed a little bit, April 1. I know of 3 areas in Pennsylvania where it's mandatory. It'll be in the Pittsburgh area, Reading, and then, let's see, where else? Harrisburg area, I believe. And what it's going to do is anybody who has a hip replacement or a knee replacement, all of their care during a 90-day period of time from surgery to 90 days will be bundled in a payment sent to the hospital. And that is going to drive then, we think, care decisions, because that hospital is going to want to, right, they're going to want to profit on it, right, exactly. And plus, a home health agency to play in that sandbox, and just, remember the sandbox, theme. Almost everything that Medicare is doing now, if they're looking at payment reductions, the other end is coordination of care and trying to break down silos. And they think that payment bundling will force everybody to play in the sandbox together and coordinate the care better, because they'll be rated then, they'll get that certain amount of money for the 90-day, and we believe that where it's going to go then is if clinical outcomes aren't at a good level, you'll get penalized. If consumer satisfaction surveys aren't good, you'll get penalized. So you see how different that is. CMS is just playing around, piloting a number of different innovative approaches. And I think none of us can argue about the fact of playing in the sandbox together and getting better coordination of care. That's got to help us. At least that's the thought. And if everybody's motivated, and there are some pushes and coordination, but the threat for home health agencies is you have to be invited to and at the table to get a contract to play in the sandbox. All right? And if you have better star ratings, if you have better data on clinical outcomes as measured by OASIS, then the likelihood of your having an invitation to play in the sandbox is higher. At least you have some tools to market to whoever is going to be the lead on the bundling payment in that situation. There are a number of other experiments, medical homes, accountable care organizations, but all of them are really revolutionary for us, and I think they're hitting home health agencies extremely, I want to say hard, but they'll impact home health agencies the hardest. SNFs are also at risk because it's interesting, before CMS made the decision to bundle the joint replacement services, I was fortunate enough. I'm on a list that I get invited to a lot of the CMS decision-making sessions, and so it really is an interesting experience, because I've seen from CMS now they're much more knowledgeable about home health than they were in the past. I used to go to meetings where they really didn't understand the industry, and you could almost write your own rules. That's not it. There are a lot of people who worked at home health agencies who are now working at CMS. They're smarter in how they're doing things in terms of services, and they're much more assertive and aggressive in terms of payment and wanting to push the envelope. For the bundling project, what they did was they did a data study, and I'm not sure how many days of time post the surgery and all of the data analytics that they looked at. But what they found, and this is the good story on the home health side, they found that clinical outcomes for patients were just as good if they went from hospital to home health as compared to hospital SNF than home health, and even comparable if they went hospital SNF and no home health. So the stress in the 90-day comprehensive bundling is going to be to try to see how many patients they can move right away hospital into home health. So that's the good news. But that spotlight will be very strong, and you have to play in the sandbox. And that is the primary item. And it'll be interesting to see what the data is. If that's successful, we suspect that they're going to target many other popular surgeries. Because, for example, one of the other test sites is Naples, Florida. You know, if anybody has a grandparent who is retired to Florida, you know they're doing a lot of hips and knees down there. So you can see they really studied that pretty well. But it is a time for us to shine, quite a bit. The other trend that I think we have to recognize is that we're under a great deal of scrutiny from contractors that Medicare engages to look at our records to see whether or not they're worth the money they're paying for, whether or not the agency is worth to get the money. I don't know whether was anybody involved at all when we got the ADRs? Staff? No. All right. An ADR is called an additional development request. And agencies throughout the country receive an ADR, and this is actually SNFs get them as well as home health agencies and hospices. And it essentially says, photocopy that whole record or put it all on a disk, send it to us, and if we don't think that the documentation supports what we paid you, we take money back. You've already been paid. Everybody's already been covered. But then they start taking money out of the next check that should have been received. And you can appeal it, but it takes a couple of years and a lot of work, to appeal. We're in the middle of some of that process right now because some of the initial documentation wasn't accepted. And that scrutiny is there because of the suspicion that home health agencies, and I mean this happens to other providers too, but now just that they're thinking, well, was that patient really homebound? Did they really meet the level of skilled care? Was that visit that was made really needed? Did it produce any real results? Was there some progress made? And you realize right now at least reimbursement, if it's in like a bundled, that episode rate rather than on a visit-by-visit basis, is bumped up because of therapy services, and you all are therapy intensive, and so you're pretty vulnerable with it. Anything that gets a bump up because of that, traumatic wounds, stage 4 wound care, as well as therapy visits, Medicare recognizes that it takes more resources to provide that service, and so they bump up the rate then. They recognize that. That's the good thing. But they audit more of those charts and look at it on a very narrow basis. And, they can come back and say, no, it really, doesn't cut what we are expecting to have on the visit. And all we have is your documentation. And this is where, when we think about it, you all are all electronic now. And aren't the clicks nice? The problem with the easy click is Medicare hates it. If you're not supporting why you clicked that, if it's anything other than within normal limits, or if it's something that triggers a reason why you're there, they want to see support for that. And that's why I think I have a love-hate relationship with electronic records, frankly. There are a lot of days when, while I like all those management reports and some of that's easy, I say, give me a clean sheet of paper. And I know, because I do a lot of medical chart reviews, sometimes, for ADRs for a number of different reasons. And I'll oftentimes look at an electronic record, and I could take the name of Mary Jones and put it there, look at another record, and it looks the same. It might have somebody else's name on it, but except for a little bit of variety on vital signs every now and again, you can almost not tell the difference from one patient to the other. And that's what we call cookie cutter, vanilla wafer recording. And so check yourself in terms of that kind of documentation. Anything that's sensitive to eligibility for skilled care and homebound, the reasons that you're really in the home, you need to support it on a more individual basis. And we all know that old adage of if it's not documented, it's just not done. And so what's acceptable? What are we looking at? Well, when Medicare, and CGS is our fiscal intermediary, it's called the Medicare Administrative Contractor in that language, but CGS, and if you're following me at all on the handout, we're down to survival tools and number 3. How is a record reviewed by CGS? If you, the hierarchy that they use is they open up the record or look at it first related to what's called the technical areas. First of all, was there really an OASIS submission? And that's pretty much done. Then they look at, are there any orders at all? And do they have orders for the particular discipline then for the visits? And then they look at the face-to-face. And I know you all aren't really involved in the face-to-face. That's more of an office kind of function. But that's a required physician or qualified non-physician, meaning nurse practitioner or physician assistant, face-to-face encounter with that patient either before admission to home health or within 30 days after, for the very reason that you're visiting. And so, and that visit has to demonstrate that there was a medical necessity for you going in and that that person was homebound. If they don't find that, they just don't even look any further on the chart. They deny it, and that's it. And that's why the office and that activity related to face-to-face encounters becomes super important. The next thing they look at is how well is homebound documented. So if you're just clicking either at admission time when the original OASIS is completed or even on your ongoing visits, if you're just clicking, well, there's it's a taxing effort to leave the home. If it's not supported on a narrative basis for why this particular patient is homebound, they're going to disallow it. And they disallow then the whole episode. And, let's talk about that. What do you need to write to support it? And let's take a look at, you have something called a home health denial fact sheet. And stop me anytime you have a particular question or want to argue with anything I'm saying, okay? And when I say that facetiously. But when, yes, go ahead.
The supportive narrative that you're speaking of, is that in the OASIS or in the actual notes?
It can be any place on your record, okay? If you're following, do you do OASIS?
No,
No, okay, all right. usually, I'm not real familiar with your electronic record. I mean, I've seen some of the printouts of it, but ordinarily where you have uh, there a narrative, like a data field that is by almost all of the OASIS elements, as well as other elements of the assessment, because we always say, everybody will say, well, I'm going out to do the OASIS. However, in Medicare's world, you're going out to do the comprehensive assessment, and integrated into that comprehensive assessment is a set of data elements that they're right up front about. They say that drives payment and it drives their data collection. It really isn't assessment. But that can be written any place. So, but most of it, and help me what yours would say. Ordinarily, you'd see it in some, musculoskeletal area, or the specific, right. Okay, and that's what I was going to say. Most software companies have something specifically that triggers homebound.
It's a section, but then there's other, and you can check off other, and you can write something
Okay,
specific.
but only, what are some of the drop downs? Usually tires easily, dyspnea, requires assistance. If all you're doing is clicking, your Medicare's not going to do it. Okay, and if you look at it, this home health denial fact sheet, and I always like to use tools, when I'm doing a session like this, right from Medicare. We're not making this up. we couldn't make up this kind of a story, really. Look, you're at the bottom element where it says, what is important to remember about homebound? That final bullet says, charting that only contains checkboxes rarely supports homebound status. Okay, it's clear, with it. And, let's just, quickly even look at the two different criteria for homebound. Because, again, those of you who are longer in the field, there was a whole time when if you just said they use a walker, that was all you needed to say. Okay, uses assistive device. Well, that's not it at all. I did a chart review actually just yesterday, and I looked at the face-to-face, and where the physician had written, using the old form yet, says patient doesn't drive. That's why they're homebound. Well, do you think that passes? There are lots of people in this world who don't drive and are not homebound, right? And so the fact that somebody doesn't drive isn't a hill of beans, okay, with it. Now, if somebody is homebound secondary to just having had surgery, so medically, but it's not like that they just can't drive because of the surgery. It's because they're homebound. They shouldn't be out where infections are. They shouldn't, So really, one of the best things, if you have somebody who's immunosuppressed, and indeed, really, in a deconditioned state, shouldn't be out, put that in. That's a good element. Persons who are confused, who shouldn't safely be out of the home, just make sure they're not signing their consent forms. All right. I see that a lot. All over the chart says demented, and then whose signature is on the consent form. That's not acceptable. But a description of, many steps helps. A description of, needing two persons down the steps. Sometimes I'll get the question, well, what about somebody who goes out to renal dialysis? Are they homebound? All right. Well, tell me how difficult it is for them to get to the van that usually picks them up, and how wiped out are they when they come back. How much difficulty is it? And the more you paint a picture, I mean, if you take away some things, like a key thing, one key message is we got to learn how to play in the sandbox. Another key item for documentation is paint a picture that's unique to the particular person that you're visiting. How difficult is it for them to leave the home? And then even with the goal setting, and we'll talk a little bit more about that with the medical necessity, but specifically what functional goals for that particular person are relevant for them. You know, we don't want them to see a record that looks the same for this patient to the next patient to the next patient. Paint that picture with them. Okay. Anything else related to homebound? You see that that you have to meet both criteria. And you just can't. Like it says, leaving home requires a considerable and taxing effort, but you can't just state that. Describe that patient.
Fears, phobias, things like that.
Yes, thank you for reminding me about that. And that's right. You know, if somebody's agoraphobic, that that helps. With homebound, but that's not going to be a whole lot of people. But it does. All of it can play within it, but you have to paint that picture with that particular person. And this particular resource does have a little bit of an example of of a write-up. And I know it's a lot of write-up, but that's what helps. Then the next really, of course, they look at that intermittent skilled nursing or therapies, and that pretty much that's an easy point to support, because I mean the visits are there. Nursing has to be intermittent, whereas therapy can be a single eval visit. But nursing can't be a single visit, and it's just how the regulation was written. It's interesting to see the regulations are in law, and no one ever wants to go back in and take a look at them. Because sometimes, like the OTs, because you realize occupational therapy under Medicare can't admit a patient to service, can't be a single service, provided. And I mean, frankly, I think OTs are like the angels. I mean, you all know function. You really help patients a lot. But why was that not done as a primary service under Medicare? Probably because you didn't have a good lobbying effort at the beginning when Medicare was being written 50 years ago. That's the only thing I can say. The same thing is true of like dietitians. They're not even a covered visit. They're not a recognized service. They really could play a big role, but it just wasn't written in. And I think this is where I say if you all of us should be very active with our legislators. When we are seeing things like right now, a lot of we're industry-wise, we're trying to argue how unfair the whole face-to-face encounter situation is now. But that plays a lot into some of the decision-making in terms of what gets covered and not. But medical necessity, then let's take a look at that. You've got a resource on it. The other paper, and my quick definition of medical necessity is, that patient has to have had either a major injury, a major, brand new diagnosis, or a major exacerbation of a chronic disease, and they need to be getting better or getting worse, and they should do so quickly. Because if they get stable during a period of time, not showing progress or not regressing so that you need to reinforce and, reteach, it's going to be deemed probably not skilled care. The complexity of what you're doing, ask yourself, do you really need a professional to do this? Or, are you doing it because there's no Aunt Martha to do it? Or, no one to come in? Are you really in there teaching a new home exercise program that then is going to be maintained by either the patient or someone else helping them? But once it's taught, and it's not acceptable to just say, well, they needs to get reinforced, and you reinforce at this visit, and then another one, and then another, unless you can document the support as to why this person needed some additional, reinforcement of something that was already taught, then you need to be planning for discharge. On this sheet is where I found my mantra of paint a picture. They say it under what is important to remember. Naturally we need documentation on all disciplines. This also tells us about the objective data. And I think that we're all getting better, especially in the therapies, with objective information. You're doing tugs, right? You're doing, so that, many particular items that are very measurable are being documented now. Question is, how frequently do you do them? You do them at admission, then again at discharge. Do you have any protocols on that?
Every reassessment.
Okay, every reassessment. Okay, what's recommended is about every 2 weeks. That's not in black and white anyplace, but weekly, because on the nursing side we say measure a wound every week. But on the therapy side, that's sometimes too fast. Unless you're only in there for 4 weeks and you're able to see a lot of progress. If you're front-loading visits, doing some intensive, that week 1, you may want to do your measures at the end of week 1. So, it's going to vary, but you want that. But don't rely only on goals. I sometimes will see that in a chart, that the only goals are that you're going to improve your objective measures. Tie it into function for the person. All right? I made yesterday was doing a mock survey for an agency and visited a patient with a physical therapist. And I could have hugged her because she had actually on the record and was working, she's working with the patient so that the patient can increase, how did she write that? Increase her endurance long enough that she could get back to preparing meals at home. That this is what her goal was. She asked this person, what do you want to do? Somebody might say, I want to be able to go to the bathroom by myself. That becomes your goal. You're using your objective measures to get there. You're still, remember on a therapy order, you need to get, it's not only numbers of visits and duration of service, and the discipline, of course, but also that by regulation it says you have to include your treatment and your modalities. So you'll use that treatment and modalities, but to get to the functional goal, and that should be how you then paint that picture of the patient in terms of what they can do then reaching their functional goal. And some other good, some ideas on functional goals. What are you using? Any thoughts?
We'll be able to get upstairs and sleep in our beds.
Okay. That's, and especially if that's where the bathroom is, and that stops you, with it. One that I like, a lot of times, if you have somebody in an apartment building especially, that they're going to be able to evacuate safely in case of fire.
Think about safety.
Right, yeah,
The safety is a
exactly.
big thing.
Yeah. So you can use your, okay, how far can they walk, okay? You figure, hey, if they live on the 22nd floor and that elevator's not going to be working, now you may not be able to stretch it that far. No. That's right. Yeah, no, I don't think that's not a... But you get what I mean. Its function and as we say, the safety element of it, because you have to think about that too. It's a good thought. But you see on this handout then some of the examples with wording. I'll call to your attention some other items, another resource that I pulled together. It says CMS language that most often is used when they deny claims. And what they're saying, just some highlighted items in that section that reads, the amount, frequency, and duration of services must be reasonable. Toward the end of that paragraph, the next to the last sentence, I really want to emphasize, taken as a whole, the clinical notes are expected to tell the story of the patient's achievements toward his or her goals as outlined in the plan of care. And in that way, your notes demonstrate why a skilled service is needed. So you're not repeating things that Aunt Martha or Uncle John could have learned to do those exercises with someone, but rather you're, based on your professional assessment, moves that person from one exercise to another, one treatment modality, to a goal that's relevant for them. Okay? Some other items that we want to stress a little bit. Page 2 of the handout takes a look at the public's perception of you. Has anyone ever gone to Home Health Compare, the website? Okay, April gets a star. All right, just Google it, Home Health Compare, and it comes up, and you can put in a name of an agency, any agency, and you will see their Home Health Compare data. And where does it come from? It comes from OASIS data elements. And I did a comparison. There are 3 different items that come up when you get to the Home Health Compare. It will be your star ratings. And why are star ratings important? Well, do you want to go to a 1-star motel or a 4-star motel if you have a choice? Okay? There are particular elements, and I think one of your weekly messages had the elements that feed into the star ratings, all right? And I know from a recent Medicare meeting that I attended, they're making the recommendation to hospitals for the bundling project for joint replacement and for Medicare Advantage programs where you have to get a contract, to not contract with agencies that have less than a 3-star. And right now you all are sitting with a 2.5-star. Okay? And I think, what's your goal? A 5. Well, you might want to work on 4 first. But, I just selected, I asked, what are some of your competitors, or who are they? And so so you can see where you compare, and I just did some of the quality, the measures, not all of them. But, patients getting better, moving around. You all are at 55%. Now, the data here is always about 6 months old. So if you've made some improvements, if you've worked on some items, it doesn't show right away. But, you're below your competitors, below PA average, below national average. And you can see there. With the one that references heart failure patients, that number is not available because you're too small of a sample size. All right. Now, why are your numbers lower in many situations as opposed to your competitors? Sometimes it really is how OASIS scoring is done, because it's the persons who are doing that assessment. We talked about that. A lot of times it's just misinterpreting the question. Sometimes it's because one person does the admission, somebody else does the discharge. And, so everybody has to get on the same page. And my mantra with that is you just want to be accurate. So, those of you who are doing OASIS, you want to know, be alert to what drives your home health compare, of course. But the real thing is to simply learn what the expectation is, be accurate with that portrayal.
Can I just give one example?
You can.
As I've been studying OASIS, one thing that I came across, if we have a joint patient and they're maybe 30 years old and they're independent with everything, but they can't put their TED stockings on and they're completely dependent on someone to do that, the question that asks about lower body dressing, you would answer that they're completely dependent on start of care because they need someone to put those stockings on, and those TED stockings are a part of what they need to wear for their medical condition. And I know for a fact that people are not answering that question that way, and it shows improvement if they answer that they're dependent on start of care, and then when we discharge that they're independent dressing their lower body. Now, I know that Mercy Home Health and Biata have drilled these things into the minds of their staff to make sure that their star ratings are high. I have not done that. There's a tutorial in our assessment, which I'm sure most people are not looking at. But if you look at it, you will see how to answer the questions properly. And if we start answering them properly, I think we're going to reflect what we're doing, because I think our patients are really improving. It's just not being reflected on how we're answering our OASIS.
Yeah, and that's what I usually find if I'm, if I do an analysis just in a situation like this, it's really because people just don't understand. I have not had the training, so that'll be pretty intensive. But also look at your readmission score was high to the hospital, and so maybe we can talk, and maybe you've already initiated, some items, but a more aggressive identification of early problems, usually. And I always treat every hospital readmission as a sentinel event. And of course, saying sentinel event reminds me that you all, and I congratulate you on this, are Joint Commission accredited. And not many agencies your size are really, and I think that speaks well really to ownership and just the commitment to it, but that will make you stand out for contracts. Right, but you need the whole picture. But that accreditation, does help you, as well as your star ratings and your compare. So you have some things working in your favor there. But then the other element that is on that website when you go on to Home Health Compare will be your CAPS ratings. And, that CAPS is Consumer Assessment of Provider Healthcare Systems. And hospitals have CAPS, SNFs now have CAPS, home health agencies have CAPS, hospices were just introduced this year for mandatory CAPS. And that's a many questioned consumer satisfaction survey. And there are some key elements that you can look at internally to help you with CAPS scores. And some of it really is, for example, when did the team discuss medicines, pain, and safety with patients? Call it that. I'm teaching you now about your medicines. If you're teaching them about fall precautions, you say, this is for your safety. Try to use some of those words and use it repetitively so that when they get their CAPS, they recognize that you did that. Because other than that, you have no control over their responses, in that, area. And I'm not sure why the last two elements of why they're rating you overall a little bit lower and not recommending, because that is something you need to work on, because a lot of the Medicare Advantage programs are wanting you to be at a 95% for recommendation, that they want to see a CAPS score for overall care and recommending. That's what they're using for many physicians now, because physicians have a similar kind of rating qualities, and for physicians to get contracts with some Medicare Advantage insurers, they have to have a consumer satisfaction rating of 95.
And I don't know if it was you that told me that insurance companies are dropping people for their star ratings and for their
That's
scores.
correct, right? Mm-hmm. Exactly. Actually, my home's in Pittsburgh, so we recently had a major insurer, Highmark, in our area, dropped a number of home health agencies from the contracts, and Grapevine has it that it was because of their ratings. They gave them notice, 90-day notice, and you're out. So this is important stuff, and this comes under that whole kind of value-based purchasing, really, that the government and everyone wants. And so we really say that you think of it, would you pay for your visit? If you had to pay out of pocket for the visit that you make, to any one visit, to any one patient, challenge yourself on that, and have that be a part of your measure. And then if you were paying, what would you be looking for in terms of documentation, to support that? I think in summary, we the last couple of items related to OASIS, and I'm sure when you read that, OASIS, who all is doing OASIS around the table? Okay, so yeah, you're both at admission, but probably discharge, right? How often are you doing an OASIS at discharge that somebody else did at admission? Okay, yeah, because that's really something to address, right. Well, it's everybody using the same standard. That's right. And I know, again, and this is, and I say this as a nurse, we find that nurses score people at admission as being more independent than they are. And therapists are more realistic with where they are. And it really is just knowing what the definitions are and being accurate. Yeah. When you see the definition of any place or thing offering a welcome relief from difficulty, as that's the official definition of an oasis, it's really kind of funny, and you want to say, our oasis is not that. There. But that oasis and the caps really are leading into public picture of you. So, have that be a message, and then just we talked about with documentation, if Medicare is seeing only clicks and not really that personalized picture of the patient with what you're working on, their inclination is to deny, deny, deny. Some questions? I think we have a couple minutes.
I mean, we're good.
Okay?
I mean, it's
All right.
around 7, but if
All
anyone
right.
has questions, feel free to
Anything?
ask questions. Yeah.
Anything? You're not okay, well, thank you for your attention.
Thank you, Barbara.
Nobody fell asleep. I didn't even see anybody nodding, so that's good. But you all have a hard role, because that's home health is really one of the few places that individual practitioners are held to such documentation standards. That's not true in hospitals. It's not, I mean, physicians have to document to, get reimbursed. But things are not as heavy at other provider settings as they are in home health. So I understand the role. But and thank you for your efforts in relation to it and sticking with it, because home health really is, isn't it where, I mean, it's where the action is now, but isn't it one of the most gratifying in working? I mean, people love you coming into the home. They'll work on it. No, I think it's a wonderful setting to work in, but I'm biased. Thank you.
Thank you all.
Just a couple things, my things are real quick. The first thing is make sure you signed in, show that you were here. The second thing is, these glasses, if anybody did not attend the holiday party and they would like one, I have some extra ones back there. They're stemless wine glasses. Some people are using them for juice glasses, whatever makes you happy. And the one thing I wanted to point out about a lot of the things Barbara talked about here today, Jennifer and I, Jennifer, I should say, Jennifer's working on brand new notes for every one of your disciplines. It's going to help reflect some of the things that Barbara was talking about. And Jennifer's also taking a lot on with this OASIS training so that she can then in turn train you on all those things so that you can answer those questions correctly. Just so you've never been that way before, you didn't think you were out there by yourself. She, of course, is doing all the work and trying to make it easy for everybody. And by the end of I'd say by the end of this summer, you'll be trained and updated to all the things that Barbara's talking about.
And by then, we'll be 5.
And you'll be.
Now you're released.
Okay.
Oh, there's calendars too. If anybody